Welcome and happy National School Counseling Week. Thank you for joining us today. I am Beth Dujak, Certified School Counselor and MBF Outreach Manager, plus the small and mighty team behind the scenes supporting me today as well. We are incredibly grateful for FISCA Board and its members, the many amazing MBF facilitators. We always like to pay special tribute to school counselors because MBF considers your advocacy to be what launched Child Safety Matters and Teen Safety Matters. A couple of items before we begin. Please utilize the Q&A feature if you would like to ask Dr. Sonu any questions if there's time. We'll do our best to facilitate feedback, even if that means a follow-up email. Use the chat feature for additional engagement, share positivity, and communicate amongst yourselves and the MBF team. Now I'm honored to share and proud to introduce MBF partner and friend, an expert in his field in the prevention of ACEs. Continue the conversation with us today surrounding the relational health and resilience topic, Dr. Stan Sonu.
Thank you so much, Beth, and thank you to all friends at Monique Burr. I'm just thrilled to continue this partnership with you all. Hello, everybody. Welcome I'm in Atlanta, and I'm glad to be joining you all again. Let me share my screen here. Okay. It's great to be here again. I was my family had such a great time during FISCA week a couple months ago, and we just enjoyed meeting so many counselors who are passionate and honestly inspiring in terms of how much you're persevering. I know it's been a difficult past few years, if not longer. We just had such a great time meeting so many of you, and I'm thrilled to be able to spend some time with you again here. Today, I'm going to be sort of rehashing a talk that I gave, the keynote talk that I gave during FISCA week in Daytona Beach a few months ago. So hopefully if you've heard it before, it'll reinforce some of the concepts that we talked about. If you haven't heard it yet, thanks for being here. I hope you'll gain something new out of this presentation. All right, so let's jump in. I always like to start presentations, especially when I'm talking about the welfare of children, with just a moment of gratitude. And the reason is because so much of what I've learned and am convicted to share with you all today is because what I've been privileged to experience as a physician. I am grateful for my patients, their families, their stories, and I have seen firsthand the incredible and beautiful power of dignity, determination, love, grace, and equanimity in my patients. And these are some folks who have experienced some of the worst parts of the human experience. So I don't take this opportunity to share with you all today lightly. In fact, it's with great responsibility that I'm going to share these things with you. But just want to express that I'm grateful to be here, and what a privilege it is to have this conversation. One thing I want to stress before I continue is a lot of times we come to talks like this, Lunch and Learn, and I think our intention is to learn some skills on what to do. What skills can I gain that I can apply immediately once this webinar completes, once it ends? And one thing I want to stress is a lot of this presentation, there are definitely going to be some strategies to apply, but a lot of it actually has to do with just being. This is a time, I like to say, it's a time to check our emotional and mental vital signs. Nothing I say here, I don't think will be necessarily new, especially for this audience. You all probably know a lot more about the ins and outs of how stress and trauma affect children. But my hope is that what I shared today is a perspective that can reset the work that you do and help you find it reinvigorating and meaningful. It turns out, just jumping straight in, that childhood trauma is the #1 public health crisis in the United States that is just hidden in plain sight. And I like to start off my presentations with this quote, not because it's necessarily something new, but it sort of reminds us that so much of what is difficult about the work that we do, whether it's in my world in patient care or in your world and in schools and counseling and meeting with families and students, so much of it is insidious. So much of it operates beneath the obvious consciousness and dynamics that and it makes it just so hard to understand sometimes, and it makes it very easy to lose perspective. But I want to ground our perspective in the fact that childhood adversity is very common and it's a public health crisis. And unless we are attuned to it in whatever sector that we're working in, it will continue to operate and it will continue to get worse. It honestly has had more of a snowballing dynamic in recent years than the opposite. Let me start off with a case that is from a real patient I saw a few years ago when I was finishing my training in Chicago. And this was when I was working at a school-based health center. So I've changed the name of this patient and I'm calling him Kyle. So he's 14 years old and he comes to our clinic for an annual checkup. And he tells me he's in good health. He has friends. He doesn't report any risky behaviors that are obvious. And his PHQ-2 or PHQ-9 depression screen is negative. However, in the past few months, his grades have been falling. And this is a change from his academic performance in years past. In fact, last year, he had made the honor roll. And he tells me, I know I'm lazy. I need to work harder. And then he asked for an ADHD medication to help him focus. And I asked him, why do you think you're lazy and why the concern now for ADHD? And he told me that it was his math teacher who had expressed concerns because he wasn't turning in his homework. The teacher, and this is kind of a summary of what the teacher had told Kyle. The teacher wanted Kyle to be evaluated for ADHD due to perceived problems with focusing. So I asked him, well, what's been happening at home? And Kyle says, what do you mean? And he went, and then I asked him again, around the time your grades changed, did anything change with your family? And he paused for a minute and he went on to tell me that 3 months prior, his father had lost his job and started drinking heavily again. And this wasn't the first time something like this had happened. When Kyle was 7 years old, his father lost his job and went through a long phase that was very tumultuous for the family of very heavy drinking. And the thing is, when his father drank, he would have these unpredictable and explosive outbursts at home, and it made everyone in the family on edge. Made everyone walk on eggshells around his father. And eventually, fortunately, his father was able to quit and find another job. But now, during Kyle's freshman year, it was happening again. And what ended up happening was Kyle would just be frozen with anxiety whenever his father would come home. Whenever he heard the car pull in the driveway, he would tense up. He was so desperate to not upset his father that he couldn't focus on doing any schoolwork at home. And so naturally, of course, this meant missed homework assignments, no studying for exams. His grades suffered. And unfortunately, no one at the school asked him about what was going on at home. Instead, his teacher, who was definitely well-intentioned, did what he knew best and tried to motivate Kyle, but with fear and consequences. So one of the most important lessons from what we have learned about the science underpinning trauma and adversity is that what we often see on the surface, and what I mean by that is behavior, doesn't often reflect what is happening underneath. Kyle's failing school performance was not because he suddenly stopped caring about school or didn't think his future was on the horizon, or because he suddenly developed ADHD after years of being a pretty good student. In fact, on the contrary, it was because his home life had become chaotic again. And the way that he dealt with it or survived it was to do what he had to do the first time it happened between age 6 and 7. And just to put a name on it, that's to freeze and appease. The poor grades was not the root problem per se. Motivation was not the root problem. Rather, it was a signal that represented a different problem. So here's the basic premise of what we know about trauma and adversity. First, adversity is universal. It cuts across every single socio-demographic category we can think of: race, gender, ethnicity, geography, community. Second, while adversity is universal, at the same time, there are multiple types of adversity that people experience that are disproportionately experienced in historically marginalized or neglected or oppressed communities. Trauma can certainly be interpersonal, and most trauma ends up being interpersonal, but it can also occur outside the home, in the neighborhood, or on a community and societal level. And then to go one step further, there are historical traumas that can impart intergenerational consequences that affect the way our physiology works. It can actually influence our biology. And there are studies that have been able to measure this. So each level here that I'm showing on the left is supported by its own body of research and literature. This isn't some unfounded theory that just sounds nice, but there is an abundance, almost an overwhelming abundance of research that have made these connections between the different levels of trauma and all of these different degrees of poor outcomes on the right. Now, what got me into this space, see, I didn't learn anything about trauma or adversity in medical school, tragically. What got me into this space was 3 months before I was going to graduate or complete my residency training. So not medical school, but the training that you do after. It's called residency. It was a 4-year program. And in my 8th year, 3 months before I was going to graduate, I attended a lecture that changed the entire trajectory of my career. It was about this study called the Adverse Childhood Experiences, or ACE study. Now, this is considered in the public health world a landmark study. It has profoundly changed the way that we think about childhood and what children can experience in childhood and how it affects our health. While it wasn't the first study that investigated the long-term impact of adversity in general, it was the perhaps most important one that was done through a public health or epidemiologic lens. It also included a participant group that most resembled the general public, because prior to this, the general sense about trauma and adversity was that those were problems relegated to the most extremes of society. People like combat veterans from the Vietnam or Gulf War, World War II, survivors of intimate partner violence, or children who grew up in the foster system. What was and still is powerful about the ACE study today is that it blew our biases about who has been exposed to adversity out of the water. Adversity is so common that we call it a universal experience, and yet this still doesn't reflect how we show up in our work, especially in healthcare and society at large. Now, real quick, I just want to briefly review the ACE study. I take it. I'm going to take a guess that a lot of people on this call have already heard about this study to some extent. And there's many great videos online that you can check out. But the ACE study researchers asked over 17,000 participants who were mostly middle class, all insured, who 75% of them have gone to college, who were mostly white. They asked about 10 different categories of adversities that were experienced before the age of 18. You can see that list there. What they found from the study was actually not just, well, let me back up. It wasn't actually just one study that was published. The ACE study ended up being a 10-year research process that led to the publication of about 70 or 80 papers. And I'm just going to summarize them real quick into 3 main findings. The first one I've already alluded to is that ACEs are common in the general population and they cluster together. So in the ACE study, 60%, over 60% of these adults had one ACE or more. And by clustering together, that means that if a person had one ACE, they were about 80% likely to have a second ACE or more, about 50% likely to have 3 or more. So it was actually less common for someone to just have one ACE and that's it. It more often was the case that if a person had one ACE, they tended to have more. So this is a more recent national estimate, not from the ACE study, but from more recent studies, the National Survey of Children's Health. And these were questions about ACEs asked to children. So not adults, but people still in childhood. And you can see nationally, 52% of children had no ACEs, but in Florida, over 50% of children actually have one ACE or more. And the current thought is that the prevalence of ACEs is actually increasing with time. It's actually a problem that is not necessarily getting better. And there are reasons for that that are outside the scope of this talk, but I think that's an interesting phenomenon to take note of. Secondly, and I have to say as a physician, this is what had my jaw on the ground. I couldn't believe it because this was so counter to how I had been taught about disease and health and treatment and how to keep people well. The researchers found this very strong link between the number of adversities people had in childhood and a multitude of health, behavioral, and social problems. The general narrative here is that the more ACEs a person had, the higher risk they would be for health risk behaviors such as heavy drinking, cigarette use, early cigarette use, IV drug use, high risk sexual behavior. They found an increased risk of mental health problems like depression, anxiety, PTSD, bipolar disease, schizophrenia, a history of suicidality. Then they found, which really kind of upset me as a primary care doctor, this link between ACEs and chronic disease, conditions that you should not see until adulthood. Things like COPD or chronic lung disease, cancer, heart disease and stroke, diabetes, autoimmune disease, chronic pain syndromes. And then they found that ACEs actually affected our lives outside of typical health domains into more socially important domains, such as academic and school problems all throughout any level of school, and then further unmet social needs, such as poverty, unemployment, financial strain. This is a summary table from one paper that was recently published a few years ago, and it's not even an exhaustive list, but I just wanted to show you the scope of how many outcomes that have been found linked with childhood adversity. What I've highlighted here are some of perhaps the most common problems that you all see every day in your schools. There's something about adversity that when it's experienced in childhood and it goes without support, is extremely disruptive and detrimental to not only our health, but how we show up socially, how we do in classroom settings, and how readily we accrue necessarily important developmental skills. So this one study found that for children, young children who have an exceedingly high burden of ACEs, 6 or 7, that the prevalence of developmental delay, any kind of developmental delay, actually approached 100%. Another study among children who were from kindergarten to 6th grade found that those children who had 4 ACEs or more were over 3 times at greater risk for academic failure. They were almost 5 times greater risk for having attendance problems and almost 7 times greater risk for having some kind of behavior problem in the school. The same study found that children, that these academic and behavior problems actually also cluster together. So over 50% of children who had 3 or more ACEs had 2 or more of these school problems, compared to only 12% of those children who had no ACEs. And this is why, and I quote Dr. Robert Ross again, he says that childhood trauma is the top predictor of misbehavior, leading to school suspension, and the number 2 predictor of academic failure. How often when a child is struggling in school, whether it's through attrition or attendance problems, behavior problems, academic challenges, how often are we looking behind that behavior and asking about what kind of experience is this child having in the home? Another study found a very extreme number in terms of the risk of learning or behavioral problems. They found that children with 4 or more ACEs were 33 times more likely to have a behavioral problem compared to those children with no ACEs. And this is a little bit of a soapbox for me as a pediatrician. I fear that we are way overdiagnosing ADHD in our clinic. And in fact, what we're misdiagnosing as ADHD, in fact, is developmental trauma. This is just one study out of many that have found that children with high ACEs are at a much greater risk of having a diagnosis of ADHD compared to those children without. It's a big deal because if all we're doing from the health system is just giving a medication to correct behavior, and we're not actually understanding what's happening behind the behavior, that it actually could be their behavior of impulsivity or hyperactivity could be a representation of the signs and symptoms of trauma, then just giving a medication is not enough. We are leaving a child in a broken state and just trying to fix behavior, and we have to do more. So when we think about childhood adversity as a whole, we can actually think about this tree, and I've shown this. I show this almost in every presentation I give about ACEs, just to illustrate that ACEs are not just experiences that occur in the home. If you imagine the interpersonal ACEs, or the ACEs that occur inside the home, are represented by the leaves and branches. The roots of the tree are adverse community environments such as poverty, violence in the community, unemployment, economic disinvestment. And then beyond this level is the soil around the tree, which can affect the tree's growth trajectory. And we refer to this as adverse collective historical events. And there's a lot of data from the field of epigenetics to support this phenomenon. Buried within this illustration is another aspect of trauma that is a little bit more difficult to see, but it threads throughout all of these levels, and that's intergenerational trauma. So I wish I had more time to talk about this today, but I just wanted to show this slide to say that adversity can show up in many different forms and is not just what is experienced inside the home. And so that being said, this slide also helps us to see how the fact that some communities have disproportionately experienced collective adversities, those things can serve to create and maintain disparities in outcomes. We have to recognize this as we approach this issue large scale. So ACEs are common, they cluster together. ACEs are strongly associated with many different health and behavioral social outcomes. The third thing that I think is relevant for school counselors to know about is how this all works. And it turns out that unmitigated adversity in childhood is profoundly disruptive to healthy brain development. Why is that? When you look at the outcomes in children, and here's just a list of some of the most common, what is the theme that we see? Well, what's important to understand here is that in children, the most common manifestation of ACEs is not actually physical disease, but it's behavioral problems. And this is a result of the changes in the brain that reflect adaptations or maladaptations to chronic adversity and trauma. I love this quote from Dr. Perry and Ludi Dobson. They're both leaders in this field of treating trauma. He said that understanding the power of traumatic events to shape the brain helps us to better determine what a child needs to heal. The punchline, and I'm going to skip right to it, is that behavior patterns that arise from ACEs or trauma are normal, predictable reactions to abnormal events. These are adaptations, not inborn personality defects. I'm not saying that it's okay to excuse disruptive or undesired or negative behavior, but really thinking about this sentence helps us to better understand that behavior in the context of what is going on in that child's life. It's a dialectic. We cannot always excuse disruptive behavior or negative behavior, especially if it's involving harm to another student or a teacher or faculty. At the same time, we can still try to understand that child's lived experience and how the brain might be responding to that lived experience, especially if it's in the context of adversity or trauma. Let me talk a little bit about stress. How can we understand what's happening on a physiologic level in response to adversity? Well, there's a lot that we've learned about how trauma affects us through understanding how our bodies and brains respond to stress. And so this is a very simplistic way of thinking about our stress response system, but I would say that the main tenets of this really hold. It's a good way of understanding how our stress response physiology operates. So if we were all out in the woods and we came across this animal, each of us would need to have some kind of immediate reaction to survive this potentially life-threatening situation. And it turns out that our brains were really well designed to deal with acute life-threatening events. It was designed for this purpose. So what happens is we see the bear, and that activates our amygdala, which is kind of like the smoke alarm center of the brain. It's an almond-shaped structure right in the middle of our brain that takes in the visual input of the bear, and it interprets that signal instantaneously as threat and then quickly activates our stress response system. The stress response system then activates our sympathetic nervous system and hypothalamic pituitary adrenal axis. That's kind of our hormone system, stress response hormone system. And that essentially leads to the release of different bioactive molecules in our body: cortisol, adrenaline, different cytokines. And so what happens in each of our bodies is that our heart rate goes up. The blood vessels around our lungs get larger so that we can exchange oxygen and CO2 more efficiently so we can run away. We have more blood going to our muscles so that we can run faster or fight harder should we need to. All of these physiologic responses happen inside our bodies, but what you might see in another person can actually vary. The output of our stress response is highly variable. Some people might fight, you first. Some people might try to run. Let me see how far you get, right? But uh, and these are sort of the first two responses that our brain wants to do. But when this isn't possible, when it's not possible to fight and win and run away and survive, we do what children very often do, and that's to freeze. It's the third best option. If we can't fight the threat and win, like I said, we can't run from the threat and survive, we freeze. And what happens is, even though our brains were designed to respond to these acute threats well, our brains don't do a good job of dealing with adversities and traumas that are persistent, especially if they're happening during periods of rapid growth and development, which is childhood. And so what happens is that these flight or fight or freeze responses can actually become embedded as behaviors that they can sort of quickly emerge whenever a child feels afraid or threatened. And it doesn't even matter if the actual event or trigger is real. That the brain doesn't care about whether it's real or not at first. It just wants to get to safety. The fight response can turn into hypervigilance, rage, irritability, a child who gets really upset and throws a tantrum or throws chairs because the teacher asked him to put away his pencil or stop messing with the eraser. The flight response can look like avoidance, anxiety, panic, or hyperactivity, an inability to sit down where the child's sort of always up out of the chair, pacing around the room or talking when he or she's supposed to be doing work. That is actually a derivative of the flight response. And this is a response that shows up when it has actually been successful in the past at the point of the initial trauma. And the freeze response can look like depression, exhaustion, numbing, dissociation. So if we were to go in the classroom and try to map these responses to behaviors that we see, it's some of the things I already mentioned. Hypervigilance can be a child who's acting out, hot-tempered, invading people's space, is hyper-competitive. You can see a child who is checked out or wants to check out. Another aspect of this is actually perfectionism, where they can't mess up, and there are certain reasons for that, but it's rooted in this sort of avoidant state. And then the child who's dissociated can look like they're absent-minded. And the fourth thing that you can see are physical complaints. So when the mental alarms and the mental behaviors that manifest from trauma don't work, they eventually show up in the body. And you can see that in the form of stomach aches that don't have an organic etiology, headaches, chest pain, and anxiety. Think about this list and imagine how often we label these children as having ADHD, how often we're focused on the behavior, and we need the behavior to stop. We need them to stop because it's disrupting the entire class. How often, like I mentioned before, how often are we trying to look beyond the behavior to what's happening in that child's life or what's already happened? I want to be clear, not all stress is bad. There are positive kinds of stress. There's tolerable types of stress where the inciting event is not a good thing, but the effects wane over time. What I'm talking about here, the thing that affects and disrupts brain development is what we call toxic stress. It's a kind of stressor that goes without support. It's unmitigated. It's strong. It's frequent. It might recur. This is the kind of stress that is profoundly disruptive to a healthy physiology. And the working pathway that we have right now is that ACEs and adverse community environments can affect the brain in development, which influences behavior. That it can affect, because it affects brain development, it can influence the way that our hormones and our immune systems are regulated, as well as our epigenome. But I'm just quickly going through this to highlight that there's multiple reasons why we see poor health outcomes or health risk behaviors or mental health problems downstream from toxic stress. All in all, what I want to stress here is that the effect of trauma and toxic stress and childhood adversity on students is not going to be the same for every child. It's not, the risk factor is important to understand, but every child is going to be affected uniquely, individually, and that has to do with their temperament, the genes that they were born with, and what sorts of supports they have available in the home or outside the home. But toxic stress does not care about our man-made distinctions between, here's healthcare and then here's social well-being and then here's education. It will disrupt whatever it can in a very multifaceted way. I just bring that up to highlight that the response or our solution to this public health problem can't just be in one sector. It just can't be healthcare and that's it, or it can't be mental health and that's it, and education and that's it. We all have to figure out how to converge on working together because this is a global problem that affects children globally. If you always do what you've always done, you always get what you've always got. It's from Henry Ford. Adversity is not destiny. And I love talking about this because this is actually why I'm so passionate and animated about this topic. I would not care so much if this was not true. If adversity was in fact destiny, what could we do? What's the point of talking about it? But we have many reasons to hope because ACEs and trauma are not the end of the story. And I would say, if you reflect on your life right now or people close to you, we know that not everybody who's experienced trauma in their youth is doomed to bad things, is doomed to negative consequences. We all know people in our lives who have made it despite the odds. Life is not perfect. It may never be perfect, but past experiences do not have to have power over us in the present. So what is it about people who've been able to live a healthy, adjusted life despite having high numbers of ACEs? Well, what it comes down to, the operative word is resilience. And I know this has been a buzzword in recent years. It's been co-opted by different sectors. When I talk about resilience, it is really from a child development perspective. And it's this trait, it's this developed trait, not something that anybody's born with, but it's this developed trait that reflects this ability to bend but not break, to adapt and succeed in the face of substantial adversity. As I mentioned, no one is born resilient. It is built through the type, quality, and number of positive adult relationships. There's social ecology. It's essential in childhood. It can also be built in adulthood. So just because there's an adult who has never had a chance to develop resilience because they've never been in a safe environment, doesn't mean that they can't develop it later on. Resilience is important because if it's present, that means that even in the face of high ACEs or future adversity, an individual can still find ways to adapt and succeed. The most important game-changing factor that is necessary for anybody to be resilient is what we call SSNRs, safe, stable, nurturing relationships. Even better if it's attuned. The answer is not a drug or some medication or some new app, program, or technology. It is the committed presence. It's the grind of a loving, engaged, caring adult over the life of that child. And I cannot stress enough that this is the game changer. This is the irreplaceable starting place for every child. Whereas adversity makes us vulnerable, healthy relationships fortify and protect us. And so for those on this call who experienced severe trauma and adversity growing up, and you've been able to be resilient and successful, I am willing to bet that you had someone in your life who not only was with you or cared about you, but understood you in a way that you felt. So everything that we do in response to this issue of trauma has to be grounded in this understanding of the importance of supportive relationships. And I think having this perspective can give us really, it can help us to innovate and think of new ideas when we have children, when we're working with children who have really gone through a difficult time and are exhibiting the behavioral problems that, again, are predictable in the setting of trauma. Resilience transforms what could be toxic stress into tolerable stress. And one thing I want to highlight here is what the research on resilience is saying, and this is fascinating to me, is that the power of protective factors is actually greater than the power of traumas and adversity. Pound for pound, ounce for ounce, the weight of protective factors is heavier than traumas and adversities. So I think for me, understanding this is, again, more energy to double down on how we support children, especially when behavior problems are present. Now, this is not to excuse or I want to be clear that just celebrating resiliency is not intended to help us justify leaving unjust systems intact or alone. We need to stop celebrating resiliency in communities and start asking, why is it that certain communities have to be more resilient than others? Why is the mountain steeper for some communities, especially our most neglected and historically oppressed communities? Why is it steeper for them, and how can we make that mountain less steep? Social connections, we know through the research, lead to these various indicators of resilience, like developmental skill mastery, self-regulation, which is really important for academic achievement, social skills, and then a healthy sense of self-esteem and self-efficacy. These are all necessary things that children and adolescents and adults, we need to be successful in society. So why are these experiences so important? It all comes down to this idea, this phenomenon of neuroplasticity, the ability for the brain's architecture to change in response to a stimulus. Just as negative experiences can affect our brain architecture, so can positive ones. And so what I want to just leave for us today, or really highlight, is this idea of promoting relational health. I want to be clear, relational health is not just about doing the nice thing or being nice. This is rooted in the science of neuroplasticity and how children's brains can essentially rewire when they're in an environment of safety and understanding. Of course, we're not family members a lot of times with the students that we work with, but nonetheless, we can play a gigantic role in representing a safe, stable, nurturing presence for our students. And again, this doesn't mean that we try to do something more or learn something new. It's all about thinking how we're showing up when we're interacting with students. So I want to highlight four broad action steps we can think about to promote relational health in our schools or even among our faculty and teachers. Putting our own oxygen mask first. Number 2, understanding the science of adversity. 3, promoting a trauma-informed culture. And lastly, focusing on relationships and flourishing every chance we get. So let me talk a little bit about each one of these. Number one, it's just, I can't skip over this. We have to put on our own oxygen mask first. You can't checklist your way to relational health with children. Children, and especially adolescents, are just, they're too smart, and they can easily pick up when well-intentioned words are coming from an inauthentic place. So the unequivocal requirement to be relationally healthy with students, it comes down to authenticity and availability, which requires integration, mind-body integration. And I think that every person on this call, just because of the very nature of the work you do, you have an ability to connect meaningfully with students. So we have to ask ourselves, well, then what then gets in the way? We cannot overlook our own experiences. And I think, especially in healthcare, the tragedy is a lot of our behavioral patterns, for example, numbing and not being attuned to our body, is a part of why we've been able to be successful and get to the places of success that we've achieved. But the thing about it is, eventually those experiences, if we keep them buried or suppressed, they catch up to us. And they really show up in our ability to handle stress. So we cannot overlook what we've been through, our own experiences, and the way our own lives have been shaped by them. What happens when we get stressed? What happens when we have days when we're dysregulated? The same things that we see in our students, especially if we're unaware or continuously operating on autopilot. So again, let me say clearly, we have all adapted to what life has brought us. And some of us might still have open wounds that show up in these reactive behaviors. And instead of feeling shame about that, the message I want to stress is that every single one of us is worthy of healing and understanding. One illustration of regulation that I like is from Dan Siegel. He's a developmental child psychiatrist who's written a lot about childhood adversity and integration. This is an illustration that we call the river of integration. When we're regulated, we can actually flow down this river of integration and handle challenges throughout the day as our best selves. We're flexible, we're adaptive, our thoughts are coherent, we feel energized, and our moods are stable. When we become disintegrated or dysregulated, we can become stuck on the bank of chaos. And this is when we have hyperactivity or hypervigilance. We feel anxious or rage. In contrast, we can sometimes shift completely to the other extreme on the bank of rigidity. And this is where we feel numb, exhausted, depressed, disconnected. Now, the goal in our day-to-day lives is not to try to avoid hitting a bank. We can't. I mean, we can't do that anyway. It's not even a possibility. The reality is we are gonna hit a bank from time to time, and that's life. That's just the way life goes. So our goal instead is not necessarily to avoid hitting a bank, but to, over time, increase the width of the river or the space between the bank so that there's more water to flow in. This increases our capacity to stay integrated. Like I said, we can't avoid challenging situations altogether. It's just not realistic. There are going to be days when we get dysregulated, but we can be better prepared for them in advance. So on your own, if you want to take a screenshot of this, I would just encourage you, if you have some time to reflect, what scenarios and contexts and interactions shift you to a state of chaos? Or what scenarios, contexts, and interactions shift you to a state of rigidity? And I think it's important to reflect on what things actually trigger us in either direction, because when we do that, we actually learn a little bit more about ourselves, and we get to the root cause we get closer to the root cause of some of these behaviors. Then I would encourage reflection on what helps to widen your zone of regulation, what helps to widen the banks between or the width of that river. And what I love about this is a lot of times it's just different for everyone. Not everybody gets recharged the same way. For me, what widens my zone is good coffee, a good book, and a quiet and peaceful place to read with a good view. It's also talking with my wife about the day after our kids go down. The simple things like that help me to feel recharged and regulated. All right, let's jump to the science of adversity, specifically understanding the science of adversity and development. And this is so important. When we deepen our awareness of what's happening beneath the behavior, beyond the behavior in a dysregulated student, we actually grow our capacity to respond with compassion and understanding. So if you're asking a question, I'm really frustrated with students right now, and I've lost the compassion that I've had when I started this job, I would say this is one useful way to go. Because in my practice, I work at a safety net health system in Atlanta, and I'm working with people who, like I said, are experiencing some of the worst parts of the human experience today. um, I can easily become frustrated at a lot of the problems that come in the clinic. However, the science of adversity has deepened my compassion and empathy in a way that I have yet to feel like it's drained, like it's exhausted. And so this includes things like remembering the ACE study and thinking about the tree of adversity, understanding neurodevelopment, and then most of all, how these behaviors can show up in the classroom. And why is this so important? Well, you can actually inform teachers or your colleagues that, look, a lot of times when we're talking to a student, we think that like the information that's in our brains comes out our mouth into their ears, up through their brainstem and limbic system, and hits their thinking part of the brain. When actuality, if that student is dysregulated, our logic hits them like this. It comes out of our mouth and it gets jumbled and stuck. And this is really a good illustration of what's happening. All that good information that we say is getting stuck in the limbic system, not in the part of our brain that is intended for rational or logical thinking. And this is what it means, in a sense, to be dysregulated. So the more we can keep this in mind, the more we understand the science of adversity, the more we can avoid thinking that a student just blank, like doesn't care, is rude, is a troubled kid, or needs to be disciplined. I want to just put this up here, and of course, I'll send my slides after this talk for your review. But a good way to talk about how the brain works in the setting of stress is the hand model of the brain. There's one video, I put a QR code of one video that I like, but just Google hand model of the brain explanation, and there's many useful videos out there. Another good illustration is the Hulk. I love talking about this analogy in the clinic. Basically, the idea is that when children are regulated and calm, they are the human version of the Hulk, Bruce Banner. But when something is activating or sets them off, they become the Hulk. And the thing about the Hulk is when he's the Hulk, he doesn't care, he's not aware of who he's hurting, what he's destroying. All he sees is red, and everything is a threat. You cannot use reason or logic to bring the Hulk back into Bruce Banner. What the Hulk needs is time and space and safety and connection. And so next time you see a child become the Hulk and you don't recognize him, remember what he needs and what doesn't work. And lastly, this illustration sort of explains itself, but we sort of have two main types of brain modes, the learning brain and survival brain. And the big picture here is when the survival brain is activated due to some trigger, real or perceived, that it inhibits the activity of the learning brain. And this is why using logic, hey, he didn't mean what he said to you, so there's nothing to be upset about. Or if you're upset, it's going to harm your future. You're going to get suspended. Like using those sort of the logical statements that work with us doesn't work well for a dysregulated child. This is the paper that the American Academy of Pediatrics published that talks about some of the physical or somatic symptoms related to trauma that is available for free online. So let me go back to our case and talk about Kyle. as I shared earlier, I think we can appreciate at this point how his change in grades was not a reflection of laziness or a new diagnosis of ADHD. He was dealing with deeply personal stress that he had no words for to explain what was happening, and he was alone in it. What we did for Kyle is we connected him with a school counselor who understood the situation right away and arranged for individual and family therapy. It turns out that the father had no idea that his drinking was causing such distress in the family. The father actually thought that he was successfully compartmentalizing his anger and frustration. And after hearing how this was affecting his son, the father himself opted to pursue rehab. And over time, as his drinking habits improved, Kyle's grades improved. So stepping back, again, I think the story illustrates why it's so important to understand the science of adversity, how it affects the brain and influences behavior, and how empathy is so important. Let me just quickly say another thing that we can do is promote a trauma-informed culture. And I think the buzzword that I would leave you with is unconditional positive regard. When we think about children, even the most difficult children we work with, um, I know this can be really challenging. But again, if we can reframe what's happening through a lens of trauma and understand that any child who experiences significant adversity without support is going to have struggles, is going to exhibit behavioral problems. This is what it means to be trauma informed. So as much as we can hold unconditional positive regard for our students, it's a great practice and perspective to maintain. Okay. And the key principles for trauma-informed care for learners is it kind of comes down to three things: safety, connection, and self-regulation. And I like the simplicity of this slide. Safety is to sort of calm down the threat center or the amygdala of our brain. Connection is another way to do that. And promoting self-regulation actually teaches children skills that can help them help themselves calm down the threat centers of their brain. And here's a resource that from Strong for Life. It's an organization that I serve as medical director for. We have a bunch of free resources on coping for different age levels of children. These are all in color. Please feel free to check out the website and print them out for your own use. They're all free. All right. So let me skip down here and just to summarize as I close. Basically, the pathway that we're thinking about right now is it goes from trauma, unmitigated adversity, we see it emotional and psychological disruption, which then leads to these behavioral patterns that developed with the intention to protect children. And when children come to school with these behaviors and they're met with a lack of understanding or punitive measures, that can cause re-traumatization. And what ends up happening is these children then learn to cope in other ways, or they continue to display hypervigilance, avoidance, or they dissociate until another trigger happens and the cycle repeats itself. And what we often see in children is that when we don't understand what's happening, when we don't understand the science of adversity, the cycle just repeats itself and repeats itself without the behaviors really changing over time. Punishment doesn't work. And eventually that child, if problems are severe enough, will either be expelled or leave school or start to participate in delinquent behavior outside the school. So when we think about this cycle, I think where we can intervene, our opportunity as school counselors or for me in healthcare, is at this point here between the reactive and subconscious behavioral patterns and the breaking that link between that and a punitive response or lack of understanding. Okay. So I want to say as I close, for many students, having a safe, stable, nurturing relationship is going to be a safe harbor that they've never, ever experienced. And the beautiful thing, but also the challenging piece about all of this is that our ability to relate and connect and be that safe harbor for children is actually related intimately to our own health and sense of being. Right now, we live in a culture in which we're either told completely neglect your well-being for the sake of the job, or the other extreme, I'm going to do me and everyone in my way better get out, better get out of the way. Neither end is a path that leads to our best selves. Self-compassion and doing the internal work is how we can show up as our best selves, integrated and authentic. And I want to be clear on this next point. Self-compassion is not just this extra credit thing. It's fundamental. It's a necessity. And understanding the ways that trauma affects the brain and how that shows up in reactivity and other behaviors, this is how we can equip ourselves to know what's happening in the most troubling situations in classrooms or in the student that we're meeting in our office. So being trauma informed is about setting standards that center on belonging, humanity, and relationships. This is how we can forge and crystallize pathways to healing that today might seem impossible. The science has led us to this point, and it is up to us to apply these insights in our spheres of influence. And lastly, I close with this in Daytona, and I certainly want to share it again because I still feel the same about it. I want to talk about this movie that my daughter for a long time was obsessed with. It's Moana. And this is a spoiler alert. So, it's been out for a few years. I hope you've seen it already, but if not, I'm about to ruin it for you here. But the brief synopsis of Moana is that she is a young girl from a Polynesian island and is set out to save her people. And to do this, she has to restore the heart of a mythical being named Te Fiti, who is held hostage by this terrifying lava monster named Taka. And at the end of the movie, Moana finally confronts the lava monster. And this sequence is just so powerful for me. I think it's spot on in terms of what we've been talking about in this past hour. Moana could not see who the lava monster really was until she understood who she was herself. And once she went through that transformation, she then had the courage and groundedness to actually look at the lava monster for who she was. And Moana saw beyond the rage and the anger of the lava monster, and behind it found pain and hurt, betrayal and loneliness. And this scene in the whole story of Moana, for me, hits on such a profound human truth that trauma can so distort who we are. But it's through the immeasurable power of connection that we can actually see who each other really are and heal. And I just wanted to end by saying that I believe that all of you here and the work that you do, for me, you are our modern day Moanas. Thank you so much.
Thank you, Dr. Sonu. I'm covered in goosebumps. Again, hit it out of the park. We are so grateful for your time today. One of the things you did a great job. I was kind of scanning through some questions and you gave them takeaways and things like that. Quick summary in terms of like best practice for that school setting, where to start as far as, staff, students, families as a whole.
Yeah, I think, if this is connecting with you and you feel like it would be something useful for, your school staff and leadership to hear, there are actually many different trauma-informed educational training programs out there. I can't vouch for them all, but the National Center for Child Traumatic Stress is a great place to start. There are some free trainings, low-cost trainings. There's even some private organizations that offer these trainings. But I would say figure out a way to get someone to come to your school and on a program development day or a special seminar offer these trainings. Just having people exposed to the information is a great start. It's not the end all be all, but if this content is connecting with you, then I would say your next step is to get some kind of training at your school. And the step after that is, honestly, I would encourage any sort of action related to students, but really figure out ways where staff and teachers can feel supported. I think, when I've had experiences when a very enthusiastic leadership gets, they catch wind of this and they see some amazing potential for patients and they skip over the well-being of the staff, it just doesn't go well. So I think the second application after just basic awareness is how can we figure out ways to support our teachers and support their integration and really and their healing and help fill their cups and help them understand the importance and skills around self-regulation. So sometimes this process is slow, but I think the last thing teachers need is someone saying, do more. You need to do this and that. You need to do more responsibilities that don't involve teaching. But I think what teachers would respond to more effectively is someone saying, we want to devote resources specifically to support you in the work that you do. Now, sometimes that might mean that system change is needed. And if that's where we're at in your school system, that's what you're going to have to advocate for. But I would start there, bring this awareness to your school because, like I said, it can be really powerful and start a sea change in the culture.
Thank you. We are so grateful for your partnership and to be able to call you a friend. For the essence of time, just as a reminder, we did get Dr. Sonu's permission to record this session. And so you can look for a follow-up email to share that information out. He's always very generous with his slides. So great information to take advantage of and share in that professional development opportunity at your schools. So all of you that took the time to join us today, thank you. We know how valuable an uninterrupted lunch hour can be. And we want to extend a very personal thank you to Dr. Sonu for your invaluable insight today.
Thanks so much.